In this video, we will talk about physiological changes during laparoscopic surgeries and anesthetic considerations related to it. Anesthetic consideration should include how to give better vision to the surgeon and also about the monitoring due to changes caused by insufflation of gas into the peritoneal cavity. So let's take a case scenario. A 50-year-old female patient having a history of jaundice, nausea, vomiting for about 1 month, and now she's being posted for laparoscopic cholecystectomy. So I will try to cover laparoscopy under 3-4 headings. Like first, which gas will be used in laparoscopic surgeries, okay, and why carbon dioxide is preferred gas, okay. Next, the physiological changes on different systems like renal, liver, CNS, eye, and the most important, respiratory system. And we know why the physiological changes will happen because of raised intra-abdominal pressure in laparoscopic surgeries. We will see how, okay? Next is what are the advantages of laparoscopic surgeries over other open surgeries, okay? And about some positions which we have to give during laparoscopic surgeries like reverse Trendelenburg and Trendelenburg. And what will be the effect of these positions again on these systems. Next is about the use of nitrous oxide, whether you should use it in laparoscopic surgeries or not, and if no, then why, okay. What will be the contraindications? Although lap surgeries are very safe, but there are still some contraindications for lap surgeries. And finally, we will see lap surgeries in like other case scenarios, like if the patient is pediatric or obstetric, a pregnant female, or a heart disease patient, or a COPD patient. First, what are the advantages of lap surgeries? Because of the small port incision size, there will be rapid recovery, lesser chance of infections, post-operative infections, less post-op pain, improve GI or pulmonary function, and improved cosmetic appearance. Let's see some contraindications for lap surgeries. First of all, shock, raised intracranial pressure. You will understand once you know what are the effects of laparoscopy on different systems. So just for now, retinal detachment, and right to left shunts. So we will be seeing laparoscopy in these headings: gas, physiological changes on different systems, advantages we just saw now, positions, the use of nitrous, contraindications, and then laparoscopic in different surgery, different cases. So let's start. So what are the properties of ideal gas which can be used in laparoscopic surgeries? Ideal gas properties. First is it should not interfere with the physiology, normal physiology. Next, it should not get absorbed. It should be excreted out of the body, okay, unchanged. It should be soluble in blood. It should not cause combustion. Now, what are those gases which can be used in laparoscopic surgeries? We can use air, oxygen, nitrous oxide, nitrogen, helium, argon, and CO2. But you must have seen that we are using mainly CO2. Why not these gases? Since the above two causes combustion, and these three, nitrous, helium, argon, they have high chances to cause embolism. That's why these gases are not preferred. CO2 insufflation starts at 4 to 6 liter per minute, and then maintenance is given at about 200 to 400 ml per minute. By this, the intra-abdominal pressure is kept between 12 to 14 mmHg. CO2 is non-combustible. It does not cause combustion. It has high blood solubility. It is inexpensive. It can be excreted out easily. You can wash it out by increasing the respiratory rate, okay? And it is absorbed. So sometimes it may cause some physiological side effects that we will see now. We will start with the respiratory system. In laparoscopy, there will be CO2 insufflation in the peritoneal cavity. This is the diaphragm. So the diaphragm will be pushed up. It will compress the lung. Diaphragm is pushed up. So it will lead to decrease in functional residual capacity and decrease compliance by about 30 to 50%. The pressures will raise, the peak pressure, the plateau pressure, they will raise by about 50 to 80%. Pulmonary compliance will be reduced by about 47%. There will be increased work of breathing in these patients. And due to laparoscopy and additionally due to supine position, there will be atelectasis in the alveoli and intrapulmonary shunting. All this will lead to hypoxemia in the patients. There will be rise in PaCO2, which will cause hypercapnia and there will be, due to atelectasis, there will be alveolar decrease in alveolar ventilation, because of which dead space will be increased. Also, there will be impaired mismatch in ventilation and perfusion. Due to hypercapnia, there will be stimulation of sympathetic nervous system, which will cause rise in heart rate, rise in blood pressure, increase contractility of heart, and hence increased chances of arrhythmias. To decrease this rise in CO2, we should hyperventilate the patient by increasing the respiratory rate and also increase minute ventilation by about 15 to 20%. Let us suppose this is the patient, this is the diaphragm, lungs, and there is rise in intra-abdominal pressure here. Now we will see some complications. If the CO2 get its way into the intrathoracic cavity, then what can happen? What can happen? Pneumothorax, pneumopericardium, subcutaneous, emphysema. So the CO2 may get collected here, okay? Sometimes it may cause shoulder tip pain also, which is although mild. If the patient is obese, then there are high chances of aspiration because of pushing upwards, diaphragm pushing upwards, okay? Embolism can occur. And if there is too much pressure, it may even lead to endobronchial intubation. If intra-op pneumothorax complication has occurred, how will you identify it? There will be decrease in saturation. There will be hypotension, sudden unexplained hypotension, the peak pressures will be increased, and sometimes there may be arrest. Cardiac arrest may also happen. And if embolism is occurring, there will be sudden decrease in EtCO2. That's a big sign. Then similar to pneumothorax, there will be hypotension, desaturation, arrhythmias, and arrest. In pneumothorax, we will have to put ICD. And in case of embolism, deflate the abdomen first, give 100% O2. If not inserted yet, insert the central line and aspirate the bubbles, air bubbles. And if the patient is in arrest, follow CPR guidelines. Let's see the cardiovascular system. So again, due to CO2 insufflation, there will be IVC compression. IVC compression will occur, which will decrease the venous return. There will be increased intrathoracic pressure. And the drugs that we have given, most of these are myocardial depressants, so they will decrease the contractility of heart. So the contractility is decreased and the venous return is also decreased. So there will be hypovolemia in the patient. There will be decrease in blood pressure and overall decrease in organ perfusion. Due to decreased venous return, there will be pooling of blood in the lower limbs, and so in the susceptible individuals it will increase the risk of DVT. Let's see the effect on other systems also. In the gut, there will be increased risk of regurgitation because of decrease in tone of LES, lower esophageal sphincter, and so this will increase the risk for aspiration. Okay, we saw there will be decreased venous return, there will be decreased cardiac output, so the perfusion to the kidneys will be decreased, decrease in GFR, a slight decrease in urinary output, but it will be reversible. Next, due to increased in CO2, and Trendelenburg position, there will be slight increase in ICP also. And if some other predisposing factor is present, then it can lead to decrease in cerebral perfusion also. It can also lead to slight increase in intraocular pressure. And in endocrine system, sometimes increase in ADH and aldosterone also. So at the time of induction, we will give GA to the patient, insert ETT, and do controlled ventilation. Okay. At the time of bag and mask ventilation, you should keep in mind to give low tidal volume. Why? Because if you give more tidal volume, it can lead to gastric insufflation, means air will enter the stomach and stomach will be inflated. So there will be risk of trocar damage. Important. And another reason is also it will obstruct the view of the surgeon. So if you have inflated the stomach, just aspirate the air out by putting a suction tube or RT. Second generation supraglottic airway device can also be used, since it will have more sealing pressure around the cuff. It has an additional gastric drain, rather than using first generation, which has increased risk of aspiration. So you can also use second generation supraglottic airway device, and you should better avoid first generation. About the use of nitrous oxide, which is said that it should be avoided in laparoscopic surgeries. Why? Because of two reasons. First, it is combustible, and another, it distends the bowel, and again obstructs the view of surgeon. Okay. So we have seen why CO2 is a better gas. We have seen the physiological effects on different systems, about the advantages of laparoscopic surgery, about the use of nitrous oxide. Now let's talk about the position. The Trendelenburg position is a head low and legs up. So what will happen? The whole blood will come towards head end. So there will be increase in CVP, means circulation will be good, increase in cardiac output, but lungs will be compressed because diaphragm will be pushed up more. So there will be decreased in functional residual capacity and decrease in total lung capacity. Also, there will be more atelectasis in the alveoli. In the reverse Trendelenburg position, there will be head up, and so all the blood will go down, but it will be good for ventilation. So the preload will be decreased. There will be decreased in mean arterial pressure, decrease in venous return, means circulation will be poor, but ventilation will be good, means respiratory function will be good. Now we will see different cases, like if you are having a heart patient or a pediatric patient or a pregnant woman or a COPD patient. Although these are separate topics, but we will just relate it with the laparoscopic. So if this is a heart patient, you should avoid increasing the heart rate. But when we are doing a lap surgery, we know that due to decreased venous return, there will be hypotension in the patient, which can increase the reflex stimulation of the sympathetic system. Okay, so there will be stimulation of the sympathetic nervous system, increasing the heart rate. And also the increase in EtCO2 does the same. So let's suppose this is heart. Okay, so there will be IVC compression, which will lead to decrease in preload to the heart. Decrease in preload will increase the heart rate. Why? To maintain cardiac output. And due to increase in systemic vascular resistance, the afterload will also be increased, which will cause the ventricular increase in ventricular wall tension, which will cause decrease in coronary blood flow, and this can increase the chances of MI in the already susceptible patients, right? How can we prevent this? We can prevent this. The EtCO2 should not be raised too much, so maintain the intra-abdominal pressure, and if the blood pressure is very low, you can maintain cardiac output. Okay, maintain the preload. If required, you can use infusions like dobutamine, and you can take the patient on invasive arterial blood pressure monitoring. Little bit about the pediatric population. Keep the intra-abdominal pressure in the neonates up to between 5 to 10 mmHg, and in infants you can keep it between 10 to 12. Now about the pregnant female. In pregnant females, already due to gravid uterus, there is so much increase in size of the uterus, it will also compress the IVC. Okay, and there is already the risk of aspiration, so rapid sequence intubation should be preferred. Next, there will be pushing up of diaphragm due to gravid uterus. Already they will be, pregnant females will be having decrease in FRC, functional residual capacity. So gravid uterus, you should remember, gravid uterus will do the same thing as laparoscopy. So due to IVC compression, it will cause hypotension. Okay, and you should keep in mind that after that, what position you are giving, Trendelenburg or reverse Trendelenburg, accordingly you have to maintain the blood pressure and other vitals. There will be increased risk of DVT in pregnant females, right? And throughout the surgery, you have to keep in mind about the FHS. You should do FHS monitoring in addition to these things. Okay, so there are some points which are relatable with the laparoscopy surgeries in pregnant females. If you know that the patient is having the history of COPD or is a current or ex-smoker, then you should pre-optimize the patient. You should advise nebulization and chest physiotherapy to improve their lung function. Their pain should be reduced so that they can breathe effectively, and intraoperatively you should keep in mind about the I/E ratio, generally kept at 1:2, but in patients with COPD the expiratory time should be increased, like up to 1:2.5 or 1:3 also. And the reason for this is to prevent air trapping in these patients. These patients already have some auto-PEEP mechanism. To understand air trapping and auto-PEEP, we have to look deeply into the COPD case. I will try to cover these terms in my next video on COPD. Alright, so thank you for listening. If you want more such content, please subscribe to my channel, and happy learning.